especially to Professor Kotsis and Professor Stavoli for giving me the opportunity to participate and to present a topic of a great relevance. The prevalence of overweight and obesity in children and adolescents has increased substantially worldwide since 1990s. In 2016, the WHO points out that there were 124 million of obese children 5 to 19 years old. Younger than 5 years, there were 41 million of overweight or obese. The two main cornerstones for developing obesity or overweight are physical activity and diet. Screen time, sedentary life, and sleep disorders while interacting negatively influence physical activity. On the other hand, sugar-sweetened beverage and sodium-potassium intake are major factors that contribute to diet. With all of these are the reasons more prevalent for developing overweight, obesity, and cardiometabolic risk factors. With this in mind, during the next few minutes, I'm going to review with you what are the most frequent cardiometabolic risk factors present in obese children, the clustering of these risk factors, and to finish off with new perspectives. To begin with the most frequent cardiometabolic risk factors, these are hypertension, insulin resistance, dyslipidemia and hyperuricemia, endothelial dysfunction, and low cardiorespiratory fitness. Let's go to start by hypertension. At this point, one important question arises. What is the prevalence of hypertension in this age group? Recently, the global prevalence of hypertension in children 2000 to 2015 was published in a meta-analysis in which 47 studies were included. From a methodological point of view, all the studies were performed measuring blood pressure by mercury sphygmomanometer of mercury. The age range was from 6 to 19 years old. Overall, the prevalence of hypertension was 4%, but this largely differs across the body weight conditions. In normal weight was 1.9%, increasing to 5% in the presence of overweight and 15% in obese subjects. The prevalence of hypertension was increasing from 2000 to 2015, and the peak was more evident during puberty. But BMI is not only the attributable risk factor for elevated blood pressure, also waist circumference and sodium intake. In fact, considering BMI and waist circumference achieve 50% of attributable risk factor for elevated blood pressure, achieving 60% if we also take into account sodium intake. Let's move on to clustering of these risk factors. It is very well known that there is a cluster of cardiometabolic risk factors in obese children. In our experience, the most frequent is the association of high insulin and high blood pressure, almost 11%. But also high insulin is associated with low HDL and likewise for high blood pressure. But this is using office blood pressure. Going in depth and performing 24 hours ABPM, the best relationship between metabolic risk factors and 24 hours ABPM was with sleep SBP at the time that the subject was in resting condition. There was a positive and also significant relationship between sleep systolic blood pressure with fasting insulin and likewise for HOMA index. In fact, sleep SBP increases as insulin, fasting insulin and HOMA index increases. Let's see the added impact of different obesity degrees, HOMA index on sleep SBP. At the same degree of obesity, severe, moderate, or overweight, subjects in the highest HOMA index tertile have not only the highest sleep systolic blood pressure, but also the steepest increment across the different categories of overweight and obesity. The urinary albumin expression is a marker of endothelial dysfunction. Considering the clustering of 3 or more parameters, waist circumference higher than the 90th percentile, hypertension, and metabolic abnormalities, those subjects that fulfill the criteria of metabolic syndrome, there were 17% overall the subject study. Among them, 4% present elevated urinary albumin excretion. Then, these children are not too prone to develop urinary albumin excretion. But even more, the abnormal urinary albumin excretion was dependent of insulin and was not related with blood pressure. Another element that has linked to metabolic parameters is uric acid. As we can see, the levels of uric acid increases as the number of metabolic syndrome components increases. At this point, it's timely to introduce a new element, the COVID pandemic and the lockdown. We know that there are several elements impacted by the lockdown: physical activity, dietary aspects, psychological aspects, and behavior. In addition to all of this, the sudden closing of the schools around the world is likely to exacerbate the burden of the global epidemic of obesity in pediatric age. It is very well known that when the schools are closed, there are more obesogenic behaviors. There is less physical activity, spend more time with screen, and there is abnormal diet. There is less regulation of what and when children eat. In addition, later bedtime displaces sleep time with sedentary or screen time activities and opportunities to snack. The final result, there is an increment in BMI. BMI increases, but in contrast, cardiorespiratory fitness decreases. Up to now, there are a few data about the impact of lockdown and that the schools were closed on the prevalence of obesity. Recently, this study has been performed in Seoul and published, taking into account 2 points. What is the increment in BMI set score? Is the BMI set score during pandemic minus BMI set score pre-pandemic, and is related with the days that after the schools were closed. Each circle is one case. Those circles that are in the gray area are those subjects that lost weight during the pandemic. In the white area, those subjects that gain weight during the pandemic. And there is a positive and also significant relationship between the increment in BMI set score and the days after that the schools were closed. But this is BMI. What about changes in weight categories? In the pre-COVID period, the prevalence of obesity was 14.6%. In COVID period, this increased to 18.6%. For overweight, pre-COVID, 9.3%. COVID period, 12.8%. But even in those children that were normal weight, some of them moved to be overweight or obese. Concurrently, there was an increment in uric acid, triglycerides, and LDL cholesterol, and metabolite vitamin D decreases. I'm reaching my last point, new perspectives, and a few words about cardiorespiratory fitness. Cardiorespiratory fitness is one of the most reliable markers of cardiovascular risk. Cardiorespiratory fitness integrates information from multiple systems, measuring the functional capacity of an individual. The most popular way for the evaluation of cardiorespiratory fitness is to perform a treadmill test coupled with a calorimeter for measuring oxygen consumption. However, this is difficult to perform in pediatric age. Considering the relevance of cardiorespiratory fitness, a group working together with engineers developed a method applying wireless monitoring technology and avoiding the use of calorimeter. The implementation of wireless monitoring technology in a clinical setting not only makes the treadmill more patient-friendly, but also gives us the opportunity to better personalize strategies to fight against obesity. In addition, cardiorespiratory fitness is related with classical cardiometabolic risk factors, is inversely related to fasting insulin, and positive related to heart rate variability as a marker of autonomic dysfunction. In conclusion, Professor Stabuli, ladies and gentlemen, obese children are at risk of early development of cardiometabolic risk factors. Blood pressure elevation, hyperinsulinemia, dyslipidemia, and increased uric acid are frequently present. Clustering of these conditions may contribute to initiating cardiovascular damage, and obviously new approaches to assess risk may provide a more precise evaluation. Thank you for your attention.